So last week we talked about enteral nutrition, and this week we'll cover parenteral nutrition. So this covers primarily chapter 4 in your textbook, and then I'll also be adding in just some tidbits from my clinical experience that I hope will be practical tips for your clinical practice. So when we're talking about parenteral nutrition support, we're talking about the IV administration of nutrients, and we're going to go into much more detail about the composition of parenteral nutrition and everything that it entails. I do just want to point out that parenteral nutrition support is considered a hypertonic solution, and with that it means that there is significantly higher risk with the administration of parenteral nutrition. And there is significantly more potential for metabolic complications, which we'll cover, as well as an increased risk of infection. Parenteral nutrition is also very costly. So a custom TPN would be anywhere from about $300 to $500 per day. And that doesn't include like all of the nursing fees associated with administering parenteral nutrition. That's just for the IV nutrition component of it. And then like a premix solution or peripheral parenteral nutrition could be anywhere from $100 to $300 a day, sometimes even more. So when we're talking about, considering parenteral nutrition support, we're looking at the overall higher costs as well as overall risk factors. It's important that we're always choosing oral or enteral nutrition when indicated, unless we really truly need to use parenteral nutrition support. So our general usage guidelines are that a patient really should only be on parenteral nutrition if they're unable to take adequate nutrition orally or enterally. And so when we think about parenteral nutrition, sometimes we do use it in addition to oral and enteral intake while we're transitioning off of parenteral nutrition, or perhaps the patient has like a long-term issue, digestive issue, and maybe they're just eating for comfort, and then they could be on parenteral nutrition support for the majority of their nutrition needs. It does present itself in a variety of different manners as far as how patients receive and meet their nutrition needs. Primarily in the hospital setting, we'll be seeing parenteral nutrition support used as a sole source of nutrition as the GI tract regains function. So when we're comparing enteral versus parenteral nutrition, so really enteral nutrition would be our preferred source of nutrition if we needed nutrition support. There's a decreased risk of infection, decreased length of stay in the ICU, and really I always like to use the mantra that if the gut works, we should use it. And as we're providing nutrients to the gut, that promotes blood flow and promotes really normal system regulation of the immune system. We're maintaining the gut integrity, maintaining those tight junctions, and having normal immune responses when we utilize enteral over parenteral nutrition. There are, of course, situations and scenarios where parenteral nutrition is indicated. So if you have trialed placement of enteral nutrition, have trialed different types of tube placements, or have trialed several different types of formula and it's not working, the patient isn't tolerating enteral, that certainly is an indication for parenteral nutrition. And then there are many scenarios where enteral nutrition is just contraindicated due to a dysfunctional or non-working GI tract. So some of those causes or causes of dysfunctional GI tract would include a paralytic ileus. Ileus just being a fancy word for the bowel is just paralyzed or not working, pretty common. Another common issue where TPN or parenteral nutrition would be indicated is with an ischemia or area of bowel death. And that could be temporary or permanent. Small bowel obstructions or fistulas are two other primary dysfunctional GI tract issues where you would need to use TPN. or if it's like a high output fistula where there's a lot of drainage, that would be another indication for parenteral nutrition. When we talk about parenteral nutrition, there are two types. So there's total parenteral nutrition, which we refer to as TPN, or peripheral parenteral nutrition, which we refer to as PPN. Total parenteral nutrition is much more common, and it is a higher osmolarity, and so you do have to have specific line or IV access to administer TPN. But the great thing about TPN, or total parenteral nutrition, is that it's more customizable and it's much easier to meet the patient's energy and protein needs. When we're looking at peripheral parenteral nutrition, it's infused through a much smaller vein. So if you think of a typical IV that you would get placed if you're in the hospital, it can be infused through that smaller type of IV. And however, it does require a lower osmolarity, which we'll talk about what that means. And peripheral parenteral nutrition rarely will meet the patient's full energy or protein needs. And usually it's not very customizable. It's a pre-mixed solution, so you kind of get what you get with peripheral parenteral nutrition. But it does have its uses, certainly. So PPN is provided via peripheral IV, and it's really designated or designed for short-term nutrition. So we mean less than 2 weeks. And the reasoning for that is that it's pretty damaging actually on veins, and so we might require frequent IV changes. We might have to poke the patient several times and move that IV every couple of days, because it actually can cause vein damage and be pretty uncomfortable for the patient. The other thing about peripheral parenteral nutrition, or PPN, is that the patient must be able to tolerate really high volumes of fluid in order to provide them with the substantial amount of calories and protein. So typically, if we are going to try and meet anywhere close to their calorie and protein needs, we would need to give them somewhere around 2.5 to 3 liters of fluid via an IV to meet their needs. And in a lot of patients, that's not going to be realistic. The other thing about PPN solutions is that typically they're a lot higher in fat and carbohydrates. Some of the premixed PPN solutions are as high as 60% of the calories from fat, and many patients may not tolerate that, especially if they already have some lipid issues. These solutions are not, if you're using a premixed solution, which is most often the case, and we'll talk about what that means, you can't really make any adjustments to the solution. So it's going to be a set amount of calories, a set amount of carbohydrates, and a set amount of fat and protein. And as you know, as we're calculating a patient's estimated needs, it may not even be close to what that patient needs. Another thing to consider is with the PPN, when we're using a peripheral IV, the osmolarity of the solution needs to be less than 900 milliosmoles, and that just is because of that vein. Those smaller veins can't tolerate high osmolarity solutions. There are several contraindications for PPN. So if a patient is significantly malnourished, you would not want to use PPN because that patient likely has specific electrolyte needs that aren't going to work. In addition, PPN solutions tend to be pretty high in carbohydrates, and so that rapid infusion of glucose might increase the risk of refeeding syndrome. If a patient has severe metabolic stress, so they're critically ill in the ICU, we don't use PPN. Or if they have a really large nutrient or electrolyte need, like I mentioned earlier, PPN solutions are they're pre-mixed solutions, and so they're not customizable. And so that we probably can't meet their needs via PPN. If a patient is on a fluid restriction, PPN is not going to be the best option for them. And then if they have a prolonged need for IV nutrition, so a need greater than 2 weeks, PPN isn't going to meet their needs. I will point out though that sometimes PPN can be a great way to bridge the gap. So say you're not sure, the patient's gut isn't working, they don't tolerate enteral nutrition. PPN might be used for a day or two until you transition to customizable TPN. So that's one way you might see it being used. Another contraindication for PPN is renal or liver compromise. And again, so with renal, the patient might need fewer electrolytes or a very specific amount of electrolytes. And again, if it's not customizable, we probably can't meet that patient's needs. And with liver patients, if they have elevated liver enzymes or liver issues, with PPN sometimes being a higher fat formula or formulation, the patient may not tolerate that higher fat composition with their liver issues. So some common complications from PPN, one is phlebitis, which is just inflammation or irritation of the vein. That's actually fairly common, and I alluded to that earlier when I said that we often need to move the patient's IV site frequently. And sometimes we just run out of IV sites that will work, and so that's something to be mindful of. There's also a higher risk of thrombosis if hypertonic solutions are used, and PPN or TPN by nature is hypertonic, so there is an increased risk of thrombosis. With certain solutions that have fat in them, it's a very high percentage of fat, so you can have issues with hypertriglyceridemia. And then, of course, the other complications are that we're often unable to meet the patient's calorie needs via PPN. And so sometimes it just buys us a little bit of time until the patient's gut function works or until we can fully transition the patient to enteral or oral nutrition. So there are several indications for CPN, which is central PN or total parental nutrition. You're going to hear those interchangeably. So you'll hear central PN or total parental nutrition. Most often you're going to hear just TPN, referring to total parental nutrition, meaning that we're able to meet all of the patient's needs via IV nutrition. So indications for total parental nutrition or TPN is that they, again, have failed an enteral nutrition trial, or maybe it's not appropriate due to a severely diminished GI function or dysfunctional GI issue. Other times that we'll see total parental nutrition being used is just with post-operative nutrition support. So again, sometimes we don't know how long the patient is going to have a GI issue for. So the consensus is that if we're not certain, the wound healing can be accelerated if we start the total parental nutrition until a patient's able to eat or tolerate tube feeds. And overall, it's really up to your clinical judgment. So you're going to consider the patient's clinical condition and deciding whether or not you should withhold or initiate parental nutrition. There are conditions in which TPN should be used with extreme caution. So hemodynamic instability, so if they're critically ill in the ICU and they're on a lot of what are called pressor support, or if their blood pressure is all over the place, it's really low, those are some times where TPN would not be used and would be withheld. If the patient has hyperglycemia, their glucose is greater than 300, We would want to get the patient's glucose under control before we infuse a solution that's really high in carbohydrates. Another term that you'll hear frequently is azotemia, and that's when their BUN is greater than 100. Total parental nutrition is typically pretty high in protein or higher in protein, and that can cause more liver issues, kidney issues if they're already renally compromised. Other things to look at are hyponatremia or hypokalemia. Those are some issues where TPN would be contraindicated, as well as the low phos. And then if they have metabolic or acidosis or alkalosis, those would be other things to look at as well. You're going to see the metabolic acidosis and alkalosis more in ICU patients. And that's something that you would look at with your clinical team to decide whether or not TPN is appropriate. Typically, you would get a patient a little bit more stable before you initiated TPN, but we'll talk about that when we look at our critical care modules. So it's important to understand IV access when we're talking about parental nutrition. So we alluded earlier to a peripheral IV, so that's just going to be your typical IV that's placed for pretty much every hospital patient. I would say that 90% of patients when they come in have some sort of IV placed for fluids or medication administration. So this is just your basic IV that's placed in a peripheral vein. It can be in the arm, it can be in the leg, it can be in the hand. And so this is the type of IV that we would be using if we were talking about PPN. The most common term that you're going to hear is a PIC, or a peripherally inserted central catheter. So that's going to be typically what you're looking at with patients on TPN. And a PIC terminates, you want it to terminate in the superior vena cava. And the reasoning for that is that the superior vena cava is a large, high flow vessel, and it quickly disperses the nutrients throughout the system. So that larger vein is necessary for that higher concentration of nutrients being administered directly into the bloodstream. So I would say most of your patients, you're going to have a PIC placed before you would initiate TPN. And a PIC, you're typically going to see it just placed that looks pretty similar to a peripheral IV, a little bit different. It's going to have a port attachment, and it's going to have a dressing on it as well. And this dressing is typically changed about once a week. Depending on the facility's practice, minimum of once a week. And so that's what you can look for there. Some dietitians who are nutrition support specialists, they actually can change the dressings and look at the PIC sites to determine if they're clean, if they're infected, etc. Okay. Other types of long-term IV access, there are things called tunneled catheters, and then there's a central venous port. These are both indicated if the patient would be on nutrition support or parental nutrition for more than 3 months is typically when they're placed. However, you might also see these, for example, if a patient is getting chemotherapy, they might have a port. Or if they've had poor vascular access, so their IVs aren't very good, or their veins aren't very good, and it's hard to gain IV access, you might see one of these long-term IVs placed. This table lists the advantages and disadvantages of each of the different types of central venous catheters. I'm not going to test you on these advantages or disadvantages. However, I think it's just helpful to know that different types of IV access exist and there's different indications depending on what's going on with the patient, and overall what their long-term parental nutrition needs might be. I think, you know, the pick with the placement and the tip being in the crease of the arm, sometimes that's uncomfortable for patients, but some patients prefer it, and it can be used for home parental nutrition. Not sure what happened there on my slide, but there is an algorithm for choosing what type of IV access is indicated. I think, again, it's just helpful to know that these guidelines exist and that this is maybe what the medical staff, the physician, is looking at when they're looking for or deciding on what type of IV to place. Again, I'm not going to test you on these at all, but it is helpful to know a little bit about line access when you're talking about parental nutrition and making recommendations. Okay, so let's talk about the different types of IV nutrition. So there are customizable types of IV nutrition as well as premixed solutions. So there are 3-in-1 premixed solutions, and so what that means is that it has carbohydrates, protein, and lipids all mixed in one bag. So the picture that I have here is a product that has all three, and there's different compartments. So this larger compartment is for the dextrose, and then these smaller compartments are for the lipids and the protein. And so they come pre-mixed like this. It's a set volume. It provides a set amount of nutrition, and you can see that there's 3 different areas, and they just hook them all up and provide the patient with IV nutrition. There are also bags where when you're ready to use it, you kind of break these compartments up and you mix it all together and you give it that way. Similar to this picture here, there's also 2-in-1 premixed solutions. And sometimes if you're giving just PPN, you might even just give that 2-in-1 premixed solution and not give the patient lipids. There's other facilities that would give the lipids separately. There are other types of IV nutrition. So there's custom TPN, where you're giving 3-in-1 TPN. And then there's custom 2-in-1 TPN, where the fat is separated, and so they call it piggyback lipids. So you're going to hang a separate vial or container with the lipids. So those are the 4 different types of IV nutrition that you'll see in the hospital setting. This is just another example of premixed solutions. Clinomix is the brand name for a product that's very common for PPN, and there's different formulations for the PPN. So you can see it referred to like Clinomix 8/14. So that means that 8% of it is amino acid and 14% is dextrose. And you'll see listed below, like for that first example, it provides 80 grams of protein per liter and then 140 grams of dextrose per liter for a total of almost 800 calories per liter. And then there's also Clinomix. There's actually several different Clinomix products, but there's 8% amino acid, 10% dextrose. There's 6% amino acid, 5% dextrose. And you can see that they all provide a varying level of protein as well as dextrose. And these products can come with electrolytes, or they don't have to be mixed with electrolytes. And then you can see that there's some products that can be used with peripheral delivery. So, for example, in the 3 types of Clinomix that I showed pictures of, only this last one is appropriate for PPN. So if you're looking at a patient and their needs, this is a liter solution. So in a liter, they would get 60 grams of protein, 50 grams of dextrose and only 410 calories. So if you have a patient who needs 2,000 calories, you're kind of stuck or limited with your options because you would need to give them quite a few liters in order to meet their calorie needs, but then you probably far exceed their protein needs. So oftentimes PPN is just providing some of or meeting some of their nutrient needs and not all of them. I'll also point out that hospital facilities probably will only carry 1 or 2 of the clinomix solutions. You're not going to have access necessarily to every type of premix solution that is out there. So you're just kind of making do with whatever products your facility carries. And then some hospitals use clinomix as these premix solutions for their TPN, their total parental nutrition. And then they use lipids on the side to meet the patient's needs. Okay. In many facilities, but not all, you're going to see custom TPN. So on the left is a cloudy solution. So a cloudy solution indicates that it's a 3-in-1 TPN, meaning that there is protein, carbohydrates, and fat mixed all into one bag. And that's going to be that cloudy white mixture. You're also going to see custom TPN in the form of 2-in-1 TPN. So that's just going to be the protein and carbohydrates and mixed together in a bag. And then lipids, you can see that piggyback lipids, just meaning that the lipids are in a separate container, but they're running usually at the same time. There are several advantages to custom TPN. So the benefits is that really it's very customizable, and it's compounded by the pharmacy. The preparation is very efficient and there's less risk of contamination during administration. If it's a 3-in-1 solution where the lipids are mixed in, there's much lower bacterial growth compared to if the lipids are hanging separately. Having all of the nutrients mixed together requires less nursing time to administer. There's more convenient storage, fewer supplies, and it's easy to administer in the home care settings. Let's see. And then other advantages of custom TPN is that it is much more customizable for fluid restricted patients. So you can use more concentrated versions of, like, say, dextrose to meet the needs of fluid restricted patients. It can be more cost effective. It's not always more cost effective. And nutrient utilization of fat is typically better if we use custom TPN, and the fats can be administered for over 12 hours. Okay. So now let's talk about the components of parental nutrition. So the first one being dextrose. And dextrose is just a version, the version that they use is really cheap, stable, and easily stored. And it's the hydrated version or form of dextrose. And so it has 3.4 calories per gram, not the typical 4 kcals per gram. So that's one area that people sometimes get mixed up on. When we're doing calculations for parenteral nutrition, dextrose will have 3.4 calories per gram. There are varying concentrations of dextrose, so you can see anywhere from D5 to D10 dextrose in peripheral nutrition. And remember that the 5 to 10% means that it's providing 50 to 100 grams of dextrose per liter. With TPN or central parental nutrition, you can use up to 70% dextrose, so that would be abbreviated as D70. And so that would mean that there's 700 grams of dextrose per liter with a D70 solution. And the reason why one might use D70 is because it's more concentrated, meaning that you can meet the patient's needs with less volume. So this is an important concept to grasp when calculating how many calories a patient is getting from dextrose, whether it's an IV solution or parenteral nutrition. So remember, if it's D70, there's 700 grams of dextrose in a 1 liter solution. So if a patient receives 300 mils of D70, how many calories would they receive? So you always want to make sure that you're putting your units appropriately. So for this one, 300 mils is the same as 0.3 liters. So you're going to say the patient is getting 0.3 liters of D70, and then they're getting, so that would be 700 grams of dextrose per liter. And then you're going to multiply that by 3.4 kcals per gram to get the total kcals. So that would be 714 kcals. So it's important that you understand those calculations in order to be able to calculate out TPN. Sometimes you can get confused and you think, is there really 700 grams per liter with D70? I think this table is pretty handy. It lists out that D5 and D10 are the typical types of dextrose that are used for peripheral administration, and then the more concentrated versions are more appropriate for central. Another important concept to understand is the maximum glucose infusion rate. So this refers to the amount of glucose that's infused per minute per kilo of body weight. And this is just because a high and rapid infusion of glucose can cause high blood sugar levels and cause severe metabolic complications. So when we're writing out TPN prescriptions, we want to make sure that we're checking the glucose infusion rate to make sure that we're not giving too many carbohydrates that would cause blood sugar issues. So the max glucose infusion rate is 5 milligrams per kilo per minute. And with critically ill patients, we oftentimes drop that threshold a little bit. So how do we calculate the max glucose infusion rate? I remember being so confused when I learned this in my undergrad course, but it's actually not too bad if you break the calculation down. So what you do is you take, you'll calculate everything out, figure out the breakdown of macronutrients that you want to give the patient, and then you'll double check the glucose infusion rate. So this is what you'll do after you come up with the total amount of carbohydrates you want to give the patient. So you'll take the total grams of carbs and you're going to convert that into milligrams. So I have an example on the next slide that we'll go through. And then you'll then take the milligrams of carbohydrates and you'll divide that by the patient's weight in kilos. And then you're just going to divide that by the total number of minutes in a day. And that gives you the infusion rate in milligrams per kilo per minute. So it's best illustrated by an example on the next slide. You'll see the glucose infusion rate abbreviated as the GIR. So if the patient is 65 kilos and there are 250 grams of carbohydrates in his TPN, what is the glucose infusion rate for this TPN order? So what you'll do is you'll first convert the grams of carbohydrates to the milligrams of carbohydrates. So you're just going to take 250 grams and you're going to multiply it by 1,000. And it's going to give you a really big number. And I think this is where most people get tripped up because they think there's no way that it can possibly be this big of a number. But this is just the first step. The second step is you're just going to take the milligrams of carbohydrates and divide it by the body weight in kilos. And then the last step is you're just dividing that number to figure out how many grams or milligrams of carbohydrates you're giving per minute. So you're going to take that milligrams per kilo number, the 3,846 milligrams per kilograms, and you're dividing it by the total number of minutes in a day, which is 1,440, and then you'll have your infusion rate. So for this example, the infusion rate is 2.67 milligrams per kilogram per minute. And remember on the previous slide, I said that the maximum that we should give a patient is 5 milligrams per kilogram per minute. And so this would be considered an appropriate glucose infusion rate. And it's actually a pretty low rate, and certainly would help with glucose control for this patient. Okay. The next component of parenteral nutrition that we're going to look at is amino acids. And amino acids are in their crystalline form, and the majority of products out there are going to provide both essential and most of the non-essential amino acids. The amino acids that are used in TPN provide 4 kcals per gram, and then like the dextrose, there's different concentrations of amino acids. So typically you're going to see 2 to 4.25% amino acids used for peripheral infusions, and then anywhere from 3 to 20% amino acid concentrations used for central infusions. But 8.5, 10, and 15% are the most common. And again, this is an example where you're probably not going to have access to every concentration of amino acids. Your facility is going to have a certain concentration or a couple of different concentration options available if they do custom TPN. This table in your textbook shows the huge variety of commercially available amino acid solutions. So there's a ton of different brand names and manufacturers for the amino acids. So sometimes you might hear, for example, a really common one is called Clinisol, that second one that's listed. So you might, when you're working with the pharmacist to write TPN, you might see them refer to the amino acid as Clinisol, and that's just a 15% amino acid concentration. You can see that there's different stock concentrations and then different brand names and then different compositions. Again, don't worry too much about like the brand names and what you like knowing all of these. It's really going to be what your facility has available for you to use as a product. Okay. Next component of parenteral nutrition, lipids. So you're going to see these abbreviated sometimes as IVFE, and those are IV fat emulsions. So just abbreviation you'll see as IVFE, especially in literature. If you're reviewing any articles, you'll see it referred to as that. There are only 2 concentrations of IVFE that are available. So there's 10% IVFE, and 10% provides 1.1 kcals per ml, and 20% IVFE provides 2 kcals per ml. When you're looking at writing peripheral or TPN orders, the maximum recommended fat level is no more than 60% of total calories if you're doing peripheral parenteral nutrition. Obviously 60% of total calories is a really high number, but that's the upper threshold that you would want to provide a patient with. More typical TPN goal for lipids is 20 to 30% calories from fat or less. That's a typical macronutrient breakdown anyway, and that's where I would normally start, depending on what's going on with the patient. And if you looked in the Aspen Core Curriculum nutrition support guidelines, the standard practice is to really limit, if you're doing IV nutrition, trying to limit your fat infusion to 1 gram per kilo per day from lipids. That's just a good guideline to make sure that the patient's lipids, triglycerides stay pretty stable. And then when you're administering lipids, you do want to make sure that you're monitoring the patient's triglyceride level, and we'll talk about that in the monitoring section. Something to note is that lipids are actually a pretty unstable, and so what they've done is they've added an egg yolk phospholipid as an emulsifier to keep the product more stable. Patients with an egg allergy may not tolerate typical lipids used in TPN. You kind of have to work with the patient to decide what they're willing to try and how severe their egg allergy is. But if you're not able to confirm that, then you probably shouldn't give the patient lipids. If they have like a mild allergy, you can't really confirm, they might be okay with it, but it's something you would want to monitor. And then with certain, or the most common forms of IV lipids, you also want to give them to patients with a soy allergy. Just something to note is when administered, if you're doing piggyback lipids or hanging the lipids separately, the maximum amount of time that lipids can hang is 12 hours. But if you're doing a 3-in-1 formula with dextrose, amino acids, and lipids in the same container, they can actually hang for 24 hours. And that's just because the addition of the lipids decreases the risk for bacterial infections. Okay. When we're looking at lipid options, this has actually shifted a little bit in the past couple of years, but traditionally, when we're talking about lipid and TPN, we're talking about intralipids, and these are the most common, and it's actually 100% soybean oil. Liposin used to be the most common, and it was half soybean oil, half safflower oil, but it's usually not used anymore. Most often we're talking about intralipid. And as you can imagine, intralipid is fairly cheap because it is soybean oil, but there are some downsides to the use of soybean oil. So one is that it has a really high ratio of omega-6 to omega-3 fatty acids. And so that combination is actually thought to be that it can increase inflammation and that it might be immunosuppressive. It also has pretty low amounts of vitamin E and might, in general, just contribute to more inflammation in patients. There are newer guidelines that state that you should be cautious about the use of soybean-based lipids in the ICU setting. So one thing that's used commonly in critically ill patients if they need to be sedated is they use propofol, and that's 100% soybean oil. And it provides some, the same 1.1 kcal per mil. And so if a patient is on propofol, it may be necessary to provide it actually might provide a significant source of fat, and you should adjust your TPN to reflect this. And we'll talk about that when we're looking at TPN calculations. The latest guidelines state that you really shouldn't provide soy-based lipids for the first 10 days if the patient is critically ill in the ICU and not stable. And the Aspen guidelines recommend providing no more than 100 grams of soy-based lipids if the patient is suspected to have an essential fatty acid deficiency, if you're concerned about that. And these are really if the patient is truly critically ill and meets some other guidelines, then you should be cautious about providing soybean-based lipids in the ICU setting. So more recently, there have been other types of lipids developed. The most recent development in 2016, the use of SMOF was approved by the FDA. And SMOF consists of 30% soybean oil, 30% medium chain triglycerides from coconut oil, 25% olive oil, and 15% fish oil. And so the research has shown that SMOF has an improved omega-3 to omega-6 ratio, and that can reduce the risk of harmful changes to the liver. And overall, they've just seen better outcomes from using SMOF. The downside is that SMOF should not be used with patients with severe hyperlipidemia or hypersensitivity to fish, egg, soybean, or peanuts. So that is almost in some ways more limiting than soybean oil. And then there is higher amounts of vitamin K in this product, so it may interfere with anticoagulation drugs such as warfarin. So that would be just something to monitor. It's not necessarily contraindication. I will say that larger hospital facilities tend to be more progressive with their use of SMOF. In smaller facilities, they probably are not using SMOF and maybe don't have the capacity to implement this type of lipid. Most facilities still have the two types of lipids, so they still have the inner lipids plus the SMOF, and then they have criteria for the use of SMOF. When I was in practice, our ability to get SMOF was somewhat limited. We didn't have large supplies of it, and so we had really specific guidelines as to which patients could use the SMOF and which patients would just get the standard lipid. So for example, if a patient had really high liver enzymes or liver issues, they would be a good candidate for SMOF, or if they were going to be a long-term TPN patient, those patients would also qualify for SMOF. Or if they were critically ill in the ICU, those were the patients that we would use SMOF for. I have heard that a lot of facilities are fully transitioning to SMOF as their primary lipid source. But I think that practice is we're still seeing out the research, and facilities are slowly making that transition as able. Another product that it's considered a fourth generation lipid is Omegavin. I will point out that Omegavin is not approved for use in the US. It's considered experimental. However, it is used in Europe. And so this one, there are no linoleic or linolenic fatty acids in it. And the early evidence shows that in ICU and surgical patients, it decreases infection, ventilator days, and length of stay. And it also has helped reverse cholestasis in TPN-dependent children. But again, the research is not sufficient to have FDA approval in the US. Your textbook does have a nice breakdown of the different types of lipids. So again, that first one, interlipid, being the most commonly used, but SMOF being kind of being a newer lipid out there. That is slowly being changed to the primary source of lipid in a lot of facilities. One thing to just remember is that if you're giving 2-in-1 solutions or PPN solutions without lipids, you do need to make sure that you're giving enough lipids to prevent essential fatty acid deficiency. So with adults there, making sure that you're getting at least 2 to 4% of their total calorie intake as a minimum to prevent essential fatty acid deficiency. Okay, with TPN, you're typically going to add an additional multivitamin to meet the patient's micronutrient needs. There are a couple different products out there. You can see the breakdown here with the multivitamins. One thing that's kind of interesting with TPN and the products used for TPN is that there are often major shortages with products depending on what's going on with different facilities. So a lot of these products are produced in other countries, and we've had a lot of natural disasters. So for example, when there were the hurricanes in Puerto Rico, couple years ago, there's a major Baxter facility there, and they produce a lot of these products, and so there are massive shortages with multivitamins. Same thing with COVID. There's been a lot of shortages with these products as well. Multivitamins tend to be a common shortage issue, and so you may not actually be able to provide the patient with a multivitamin every day. As you get into your practice, Aspen on their website has really good recommendations on how to handle product shortages. So that could be something that you could look at as a resource. In addition to a multivitamin, there's typically a standard trace element product that you can add to your TPN to meet the patient's needs. It contains, several different trace elements, and typically you add about 2 mils to meet the patient's needs. However, with custom TPN, you do have the option to add a couple of the trace elements separately, so you could do like a standard product, or if your facility compounds the TPN there, you can add specific amounts of trace elements as needed. One thing to note is that we don't add iron to TPN because of potential for severe allergic reactions. It also is not a very stable product, so you need to make sure that you're meeting the patient's iron needs in other ways, especially if they're a chronic TPN patient. This table just highlights some trace element deficiencies that can be associated with long-term parenteral nutrition, just something to keep in mind. Okay, and then we can add medications to the TPN as well. So it's pretty common for patients specifically in the ICU or GI patients to have H2 blockers added to their TPN. And then insulin can actually be added to TPN as well. So it's regular insulin, and it will be added if the patient has diabetes or steroid or stress-induced hyperglycemia. And something that's really interesting about adding the insulin to the TPN, it does help with better glucose control, but about 50% of the insulin sticks to the plastic tubing in the bag, so you have to adjust the dosage of the insulin knowing that. This is just an example of what it might look like for dosing insulin via or adding insulin to the TPN bag. And so there's different guidelines based on the patient's A1C or what their last blood glucose reading was. And you can see that there's different ratios used depending on what's going on with the patient. You definitely do not need to know this or memorize this, but I just wanted you to know there are really specific guidelines for how you would add the insulin to a TPN bag. Okay. Another thing we'll look at is how you initiate TPN. So you definitely are going to be working closely with pharmacy and the doctor to pay attention to the patient's blood sugars. And so if they're on insulin or other blood glucose medications, or they have a blood glucose greater than 200, then you wouldn't want to load them with a lot of carbohydrates on the first day. So we would just limit it to 100 grams of carbohydrates on the first day and see how they react so that we have time to adjust their medications and their insulin to keep their blood sugars nice and stable. And then we would also hold the parental nutrition if they had a blood glucose greater than 300 or we were really struggling to get the patient's sugars under control. It is really common to start the TPN at half TPN, so meaning you're just going to provide the patient with half of their nutrient needs on that first day, just because the infusion of nutrients via an IV is very different than providing the nutrients enterally or orally. We do this to reduce the risk of refeeding syndrome, hyperglycemia, and hypervolemia. And in patients with refeeding syndrome, it might actually take several days to reach their goal TPN. The GIGAS guidelines here show that we would, for a patient at risk of refeeding syndrome, we should initiate nutrition support at 10 kcals per kilo for severe cases and up to 15 to 20 kcals per kilo for moderate cases of refeeding syndrome. So you do want to consider all sources of calories and fluids, so propofol and as well as IV dextrose. With patients who are at risk for refeeding syndrome, you'll definitely check and replete their electrolytes prior to starting TPN, and you'll monitor their electrolytes every 12 hours until stable. And then you would actually only increase their carbohydrates, that should say 200 to 300 calories every 2 to 3 days. And so you would slowly increase their kcals until they got to their goal amount, and you'd be checking their electrolytes and their signs and symptoms of refeeding syndrome until they've stabilized. Looking at transitioning a patient off of parental nutrition, in school I was always taught that we should transition a patient from parental to enteral and then to oral. So as soon as it got worse, we start using it, and then eventually the patient hopefully would be able to tolerate oral intake. However, in actual clinical practice, we will often see a transition from parental nutrition to oral intake, because as soon as the gut works, we're pretty optimistic and hopeful that the patient will be able to fully transition to oral intake. And if you think from a practical standpoint, your physicians and doctors aren't going to want to place a feeding tube just for a couple of days of enteral nutrition. That could introduce a lot of complications or other variables. And you think from the patient perspective, they probably don't want to have a feeding tube placed either, unless they absolutely had to. So we will see both kind of transitions happen. Sometimes we'll see the parental to enteral to oral if the patient has swallowing issues, cognitive issues, something else going on where they can't make that jump from parental to oral. But if the patient was on it for a gut issue, GI issue, and then that resolved, we're going to see a transition from parental to oral intake. So in general, we would continue parental nutrition until 60% of the calorie needs are being met enterally, or I would recommend continuing parental nutrition until 75% of the calorie needs are being met orally. And the reason for that difference is just because oral intake is a little bit less predictable than enteral nutrition. And so you want to make sure the patient's able to meet their needs orally before you completely stop the parental nutrition. And typically it's kind of sometimes if you're using custom TPN, you're going to be tapering down on the parental nutrition amounts and increasing the enteral or oral intake. So you're kind of doing a give and take with those. Just something to look at when you're doing transitional feeding. All right, as far as monitoring goes, when you're monitoring patients on TPN, you'll be checking in their daily weights. You'll also be checking their I's and O's, their inputs and their outputs. You'll be wanting to monitor vital signs, and then looking at the patient's labs. Lab protocols will really vary between institutions and facilities. and they'll have a specific protocol. So I just included a protocol that we used to use at my facility. It looks really complicated. It's not that complicated. Most often patients are having labs checked every single day anyway if they're in the hospital setting. And so these are just standard labs, and then there's a bunch of additional add-on labs. One thing to note is that you do typically want to check the patient's triglyceride level when you start TPN, just because there is a higher risk of liver issues and hypertriglyceridemia with TPN. Okay. All right, so in a separate little lecture, I'll just talk briefly about the complications of TPN, and we'll go from there.